Hello and welcome to the World Extreme Medicine Podcast. I'm your host, Stephen Wood, and I'm joined today by Dr. Aimee Tang. Dr. Aimee Tang is an emergency medicine physician at Jewish Memorial in Long Island, New York. She also has an MPH, which she earned at UMass in Amherst. She completed an international International Emergency Medicine Fellowship at Northwell Hospital Systems, and does a lot of work in the international and low resource setting, which is going to be the topic of our conversation tonight. Am I wrong when I'm saying, Tang is kind of the beverage of astronauts, but there's no relation there. Your family didn't invent or isn't involved in the Tang industries?
Only the orange flavor, but the
Only
rest is
the orange
not
flavor? Great.
not.
Great. I think anyone who does expedition medicine, at least in the United States, I think is well familiar with Tang. So I just thought I'd throw that out there just to make sure I didn't miss anything.
Mhm.
But I'm excited to have you on as a guest today. I'll reveal that we actually worked together as colleagues a number of years ago. I think too many years, actually, maybe to mention.
Yeah.
Although I feel I'm still looking quite young, as you are as well. We worked together in emergency medicine research, doing research on sepsis. And then we both have stayed in emergency medicine and have worked both in academic medicine and I've worked in community hospital settings. I know you've worked mostly in the academic setting, but have worked extensively in areas that are kind of low resourced and underserved. So, we both kind of have a background in EM. We both have a background in working in these kind of austere environments, but clearly, you have really taken that to new levels and have done quite a bit of work, both in Haiti and in India. And that's what I'd like to talk about today. So tell me a little bit about yourself and then your experience, and then we'll kind of talk about, how you've engaged these, low resourced communities in emergency medicine.
Yeah, thanks. And global health has always been something I've been interested in. It kind of is like one of those things that drives a lot of people to medical school. You want to help low resource communities, you want to help people around the world. And pairing it with emergency medicine is kind of a non-traditional path in global health. Usually when we're talking about international medicine, we're talking about public health systems, we're talking about infectious disease, tropical diseases. But emergency medicine is something that's kind of developing as a new field in a lot of communities around the world. And so it's kind of an exciting thing um, to kind of be involved with that and kind of be involved with bringing emergency medicine health systems, as well as education to some of these communities.
Yeah, I think, even in the United States, emergency medicine is a younger, field. It's only, been around, I think 30, maybe 40 years as a
Yeah.
practice. Even when, yeah, more, when I started as a paramedic, people that staff the emergency department could be an endocrinologist, could be OBGYN. I think the specialty of emergency medicine is really still pretty young, still developing, even here in the United States. But it's, yeah, but it's still, fairly robust for the most part. What has been so you've worked in a couple of different areas. You've worked in Haiti and you've worked in India. You can talk about either experience. So what's been your experience with whichever of those you want to talk about first with, what's their level of, service in emergency medicine? How are they structured and what has been your experience there?
Yeah. So, like you were saying, within the US, EM is still pretty relatively a new field. And so, emergency departments or urgent care centers, where people are seeking more immediate, acute medical care, is being staffed by physicians who are not trained in emergency medicine is a very commonplace now in some of these other countries around the world, in these low and middle income countries. Where we were 20, 30, 40 years ago is kind of where a lot of these communities still rest now. And the problem with that is a lot of these doctors who are trained in community medicine and primary care, they're not trained in emergency medicine and how to deal with acutely ill patients, how to resuscitate acutely ill patients. And that's kind of a niche that's very specific for the emergency physician. And so training physicians, training students to deal with a lot of these emergency medical situations has been super key to a lot of my work. Both in Haiti and India, those are the two communities that I've had the most experience with. It's a very good example of two very differing stages in emergency medicine developments. Haiti is very, very young. I work with hospital, HUM, Hôpital Universitaire Mirbalais, which is the university hospital in Mirbalais. And they have the one and only emergency medicine residency in the country. They have 5 to 6 residents per class. It's a 3-year program. And the first year, the intern class started in, I believe it was 2014, 2015. So, I mean, not even less than a decade ago, they've only graduated three classes. So emergency medicine is very fresh there. Whereas in India, I would say India is a little further along, but there's still not, emergency medicine still isn't a routine and widely accepted field. And so emergency medicine education there is a little bit more piecemeal. And so it's kind of interesting to see how EM can and will develop in these countries and these communities over time. These communities are basically where we were a few decades ago, and hopefully they will only see growth as, emergency medicine continues to grow and these physicians go out into the field and do their thing.
Sure. And I think, it's important clearly to have that structure of training emergency medicine physicians and, doing that through a residency program. But I think, and I'm not sure if you can or can't speak to this, but the other challenge I think is then that support of nursing. Nursing is obviously really integral to, managing an emergency department. I'm sure, we both know as EM providers that you rely a great deal on your nurses for recognizing when patients are sick, as well as, performing interventions like IV access and things of that nature. And as much as you need a robust, program of emergency medicine physicians, nursing is also really integral to that. What's your experience been? And again, we can compare and contrast, Haiti and India for kind of nursing support. Do they use nurses like we do here in the US that are, specifically and specially trained in kind of the emergency setting, or does it vary?
No, that's a great question. I mean, I think that's one of the big challenges that is posed to when we're building emergency medicine systems or communities in these communities is that it's not just about, training emergency medicine physicians, but it's also about building that infrastructure that surrounds it, in terms of ambulances or having people come in and nursing staff and other ancillary staff, having, lab techs that are available 24/7, having radiology techs that are available 24/7. For a lot of the services that emergency medicine needs to provide, there's a lot of resources that go into that. With nursing in particular, I know that with a lot of the programs that I've worked with, education for nurses has also been, part of it, because we do recognize like a lot of what we do is very much reliant on our ancillary staff as well. Especially in these communities where physicians may be few and far between, having a medic or a tech or a nurse, somebody who has some medical background, but not necessarily a physician, sometimes is a lot more available to patients. So whether it be specific training programs for nursing, or even just hands-on experience we've had a lot of nurses who've come down and worked specifically with the nursing and ancillary staff. I mean, just in general, so the WHO has recently put out this basic emergency care program that they're trying to roll out. And it's essentially geared towards not emergency medicine trained physicians, but any healthcare provider that basically serves as a frontline provider to, patients who might be in emergency medical condition. So patients who have a fever, who are after some traumatic accidents, the basic bread and butter emergency resuscitation cases. There are a lot of providers out there. There are a lot of communities out there that, don't have access to a hospital or even a clinic nearby. It might just be, a nurse who, lives down the street, or, a small physician within, how many miles, how many in cities nearby. So having, somebody there who's first line and front line, who's trained in basic emergency management, how to resuscitate a patient, how to recognize sick patients, and knowing when to transfer patients out and what patients need. Simple things like that are a huge key to bringing emergency medicine into these communities. It's not just about emergency medicine training physicians, but training ancillary staff, training primary care providers, training nurses, training other practitioners, EMTs, techs, people like that, who also have a huge hand in emergency care around the world.
No, I think that brings up a really good point, and something that, we don't think about much here in the US because we have so many designated professionals, but this is the point that I think you bring up, is just the importance of community health workers. And those don't have to be certified people. These are just people that have worked in the community. They're trusted, and they can be, trained to understand some basic principles of emergency care. That might be even more important than, a small residency program in a country like Haiti, where they're putting out 5 providers a year. That's just not going to be sufficient to manage a country that does have, high rates of morbidity and mortality and lots of trauma. I think, the community provider can actually be really integral to that. ATLS, or Advanced Trauma Life Support, which we have here in the US, kind of follows a similar model where they're training, really emergency medicine providers that are in community hospitals, to manage trauma in that quote unquote golden hour. I think, what you're describing, the World Health Organization trying to integrate, these community health providers, or allowing, people that have, some at least medical background to have some basics in emergency medicine, that's really integral to how you might need to integrate a system in kind of an under-resourced country like Haiti, India, or many, many others.
Yeah,
So
absolutely.
really
I
great
think
point.
something we also take for granted here is just, especially when we're living in metropolitan cities in the US, how easily accessible like a hospital is, a clinic, a medical center, some sort of medical facility. Like there's probably dozens within 10 miles of me here in New York City. But there
Right.
are a lot of communities out there around the world that, not only are these health centers far away, but they're not easily accessible. There's no paved roads, there's no cars, you're hiking, you're, motorbiking, you have no transportation, there's no system in terms of transportation to get you to a lot of these places. And a lot of these places are very isolated because of that. So, just going to a hospital for any quote unquote emergency you might have, or medical issue you might have, is, not very feasible logistically. And so, you know, community health workers are a huge part of what we do, and what needs to be done as we move forward with bringing emergency medicine and prioritizing emergency care around the world.
Oh, sure, of course, of course. So let's talk a little bit then specifically about some of the work that you've done. So, what are some of the projects that you've been able to bring to these countries, and then we can talk a little bit about how these projects came to be, and maybe discuss a little bit of the challenges. So let's start with what are some of the projects that you think you've been able to successfully implement in these kind of settings?
Yeah, so my particular interest is emergency medicine development, and we do focus a lot on residency programs and teaching. Um, so, generally we are teaching residents, we are teaching physicians, and a lot of it's teaching from the ground up. So it's not just learning emergency medicine in terms of like the medical knowledge and the procedural knowledge, but it's also about medical education in terms of, um, how do they become teachers in themselves? How do they, because they're going to be tasked with further spreading emergency medicine in these countries. In Haiti, for example, these few residents who graduate, they're going to go out into the community, and it's going to be on them to bring more people into the emergency medicine field. It's something that we say a lot in global health, but, our job is basically to make ourselves obsolete. We come into these places, we want to, bring emergency medicine, we want to teach them, but eventually we want to be able to step out of the picture and leave it up to the locals and people who are from that community to take over and to take on the rest of the work. So I've focused a lot of, on creating basically like very basic emergency or just medical education training programs. So very simple things like, for these residents, we do a 2-day course in how do you teach? How do you teach another medical professional? How do you teach a nurse? How do you teach a medical student? How do you teach another resident? How do you teach adults, which is a different beast in of itself. So there's a lot of specifics there, but the idea being not just that we're teaching emergency medicine, but we're teaching these people um, how to continue the chain, right? How to continue to teach others and then further propagates the knowledge that they've learned.
That's great. And I think honestly, that's something even in our US system, we don't necessarily do very well, which is, teaching residents to then be able to teach future, residents. They're just struggling to get through that residency.
Mm-hmm.
And it's probably later on in their career that they learn, good methodology for passing on the information they've learned, how to share that information, how to, share that information, not with just, physicians, but with respiratory therapists, with nurses. And that's not an easy task. That can be, kind of difficult to do. And especially you mentioned, doing that with adult learners can be even more difficult, especially people who just have this rote way. But I think that's, a fantastic concept, and I'm delighted to hear that that's the kind of ideology that you're bringing to these programs, because it's just so important that you're right. We pass that baton so that you become an obsolete program, and that they then carry that forward and become the educators bringing emergency medicine to these environments.
Yeah,
Um,
exactly.
yeah.
In India is like, like I said, India is a little bit further along in terms of how long emergency medicine's been a field in India. The program that we work with, we've been running for several years, almost a decade, I want to say, way before I even started there. But, there's local faculty there who've, gone through the program, who stayed on and who are now, teaching in charge of the residency program and who are teaching there and who've moved on to other hospitals. So, our footprint there slowly becomes less and less. Local faculty has taken over a lot of the education, a lot of the teaching to the residents and to the staff there and to the community there. And so it's a slow process, but it's nice to see the step-by-step movements of how a program grows. It's slow, but
Right.
it's definitely important that you have buy-in from your local community.
Well, absolutely. I think it's all, and I'm hoping you include how to complain about other specialties as
That's
well.
always, it's a natural.
Yeah, that should be at the top of your list. I spent a number of years as a paramedic, and then the last 12 years in emergency medicine. I'm now working in the intensive care unit, mainly driven by COVID, but now I've definitely found that I just really love the ICU. But it's funny, I did at some point make that transition to now I complain about emergency
Yeah.
medicine on a
Like,
regular
why are
basis,
you
which is
consulting
nice.
on this?
Right. Why are you consulting us for this? Why didn't they do this? Why didn't they order this lab?
Yeah.
It's a wonderful experience to be able to do that. Have you had any challenges? Have there been any, programs that you've tried to institute that you felt just didn't go well, but you were able to learn from? Anything that kind of fell on its face where you had a really great idea, you tried to implement it and it just didn't work?
Yeah, I mean, all the time. That's
Yeah.
the one thing you learn when you start working in global health is nothing goes as you plan. And I think one of the difficulties is, we're not on the ground. And it just goes to show how important it is to get buy-in from the local community or somebody local there who's going to be able to help you with the program.
Yeah.
Um, in India, for example, I've tried to run various research programs there, start research studies or work with some residents on that. But it's hard when you're doing it with, a 12-hour time difference and
Right.
over internet, over, WhatsApp, over email. It's hard doing things from afar. A lot of programs will say, being there in person is going to be a help and it's a good way to get things actually started. But unfortunately, sometimes the distance is too much. Sometimes it's just not feasible to be there full time, or even a large amount of the time. And especially now in times of COVID, when we're not traveling at all, you know, that's it becomes a very difficult thing. Planning and implementing a lot of programs, a lot of whether it be research studies or teaching programs or lectures, just like simple things like that becomes a lot more difficult.
Oh, sure,
You're not
sure.
there. Yeah.
Sure. And I think that's another really great point too. You mentioned that you really have to bring in those community leaders to buy into these types of programs. And I think, that's probably an area that I've seen where organizations try to go in to a location. They don't get the buy-in from these community leaders. That's destined to fail.
Yeah.
That buy-in is incredibly important. And I think that's a really good point, for our listeners that are, engaging in these types of programs, getting buy-in from those local leaders is really integral. And then, it is important to have boots on the ground in many cases, but you also have to be adaptable. And especially now with COVID, and I think a lot of places now are going to limit travel regardless. They're going to realize these things can be done, through via Zoom and other, outlets that might kind of change that. What's your thought on that? Where, how important is being boots on the ground versus offering something, through Zoom or other kind of programs like that?
It's Yeah, I mean, the field of global health is going to change a lot because of COVID, just naturally with the limitations on travel. I think it really depends on where you are with the project. If you're starting a project from, day zero, um, being there in person cannot be replicated. Being there, you have to be there to make the connections to build that, find that buy-in and build it with the community. That's so important. I can't tell you how many global health type programs or people who are very well intentioned, but they have very unsustainable projects in mind because they don't think of involving local community and local people. Without that local buy-in, your program's unsustainable. Your program's not going to have the impact that you want it to have. So especially in the initial period where you're bringing this program in and starting it, being there in person is going to be a huge help. And it's slowly as things build, you can step away and you can do more things remotely. Um, Obviously, that's going to change a lot now with travel restrictions with COVID and everything. But I mean, I think it's still very important. I know in India now we're doing Zoom classes to the residents. So once a week, a US faculty member will log on to Zoom and teach to, the local residents in India. But, there's always challenges to that. It's a 12-hour difference. Getting engagement over a camera and the internet is not the same as when you're in person. Getting everyone to log in at the same time, finding a time that's suitable for everyone. There's a lot more technology and other logistics that come into play, so it's going to change a lot of what we do. It's still feasible though. It's just reworking, reimagining what we do and how we're going to do it, how we're going to teach.
Right, right. No, that's great. The other thing I kind of wanted to ask you about was, I think especially U.S. based programs, we go in thinking that we're going to do all the teaching. And in other projects I've been involved in Haiti and Iceland, we've kind of gone in with that mindset and then realized that these programs have a lot to teach us as well. And that even though, we come from these academic centers, there's a lot we can learn from these, other organizations. They've been able to, take what limited resources they have and do some amazing things. Do you have any stories or examples of where that's, been the case in Haiti and India, where you've just learned something that really kind of changed your practice, changed your mindset on your approach to emergency medicine?
Yeah, so much. You know, like you said, a lot of these people, these communities are so used to working around constraints and resource limitations that they're so much better at it than we are. I remember when I first went to Haiti and saw the nurses priming pumps, and they don't have IV pumps, right? So they're counting droplets and, titrating by drops, things that, you don't even think about, creating sea collars using, cardboard and, rolled up towels and blankets. They're able to improvise with what little resources they have. Treatment's a lot different there when you don't have access to a CT scanner, when you don't have
Right.
access to an X-ray, maybe routinely, or labs that are going to come back in a timely manner. Your practice medically changes a lot. I One of the things that I think when I first worked globally was just the management of DKA. So like a diabetic coma, a diabetic emergency. here in the US, we have IV insulin, we have all these treatments, we have these labs, we calculate blood gases and anion gaps and all these different things. And these are not readily available in some of these communities. So, we do a quick finger stick to see what their blood sugar is, see if they have sugar in their urine, and do an EKG. Does it look like their potassium's high? We start insulin sub, like everything's a little bit different.
Right.
And, coming up with those and like thinking it through to that extra step, without having the normal resources and the normal data that you would have, that I'm used to having, that we all are,
Right.
is very different. So it's definitely a learning experience to work in these communities and to work with these limited resources and kind of like try to MacGyver it and figure out how to work around these constraints, because it's possible. These guys do it every day and they do it successfully.
Right.
And it makes you realize how reliant we've become on technology, on, these very fancy machines and lab tests and consultants. And sometimes, you just got to do what you have to do. And you don't need that to be a doctor. You don't need these fancy things.
Right.
You can still help people. You can still save lives with smaller resources. You just have to be a little bit more ingenious about it and a lot more flexible.
Oh, yeah. I mean, I'm a disciple of Jerry Hoffman. I don't know if you're familiar with Jerry Hoffman, who is a very outspoken emergency medicine physician who really talks about so many of the things we do are unnecessary and could be obtained through good history, good physical exam. And I think that, my experience in Haiti and in other kind of austere environments has really kind of made me kind of rethink, my own practice, and to try to be more cognizant about ordering fewer labs. Imaging is a little bit more difficult to get away with, but, trying to limit it to things that are going to maybe, make a difference, and, reduce the amount of kind of extraneous things that we do in emergency medicine and in the ICU that's carried over into that setting as well. And I think, you spoke really eloquently about that, which is that, when you leave your, your remote setting and you're back in your ER in New York, right, you have all these resources again, and you can just go back to just, ordering labs and ticking off boxes. But I think it really does give you this sense that, wow, I really want to be a thoughtful clinician and kind of, listen to that history, listen to, do a really thorough exam, think about what's necessary, what isn't, and then what my downstream resources are going to be. So I think, I felt that it's changed my practice. Seems like it's done the same for you.
Yeah, exactly. I
In
mean,
that
like you
regard.
said, a lot of what we do goes back to our history and physical, like very basic, simple things. You don't need anything fancy for it. And sometimes we rely more on these technologies, on these imaging, on these tests, and we let the history and physical fall by the wayside. Um,
Yeah.
and it feels very wasteful, especially when you come back from these communities and from these very low resource settings, and you go back, I go back into my ER and everyone's getting a CAT scan and everyone's getting an MRI, like things that you're like, is this really necessary? Like, we're
Right.
wasting so much, compared to these communities that are making do with so little. The disparity is very shocking, and so it's humbling. It's very humbling to see the difference and to kind of take that into your personal practice.
Yeah, and supplies as well. I mean, we're so incredibly wasteful with opening up kits and throwing away, three-quarters of it. And then you think about just the limits that they have for accessing suture material
Yeah.
or, scissors and those kind of things. It really, really changed your practice. We're going to wind up here in a few minutes. So I want to just ask you if you had a couple of, so I'll ask two different questions. And the first would be, if you're in emergency medicine or you're thinking about going into emergency medicine and you want to get involved in kind of doing, kind of the things that you're doing at the, the public health efforts, or bringing emergency medicine to these austere environments or these low resource environments, what are some things that you would recommend for, people with this interest and how they could pursue that kind of, experience?
Yeah, I mean, so I tell residents and students all the time, if you're interested in global health, you kind of have to do it. Go ask people who are involved in it, ask how you can get involved. And there's a lot of global health programs out there. There are a lot of global health missions, and people doing a lot of things in the global health world. I also would caution people to be very discriminate when you're looking for programs to help out or to apply yourself to, because there's a very clear difference between medical tourism, where you're going to do a mission, but you're learning Spanish while you're working in this clinic in the rainforest, there's things that aren't medically necessary or helpful to the community, and it's more just for your experience, versus things that actually make an imprint, have a good imprint to the local community, really work with local people, and provide needed medical resources. So it's one of those things. It's like you have to do it to really know if you like it. For me, for example, when I was a resident, I knew I had this interest in global health, but I sought out programs where I could go and work in these communities and work with people in order to just experience it, to see if it was something that I liked and really wanted to pursue. So, having that experience, when you're a student, when you're a resident, when you're in training, is going to be very helpful for that.
That's great advice. And I think, for our listeners that are interested in that kind of work, I think that's an important take home message. And then I want to, we'll finish up with, do you have one story of your favorite experience for, your work, something that really kind of opened your eyes or brought you some joy? I think I'm supposed to lead with that because I learned that dopamine, when you think about a good experience, it releases dopamine into your brain, and then actually that enhances learning. But we're at the end, so I guess maybe they'll just have to rewind this and re-listen. But what was one experience that brought you some joy, or brought you that you felt was just a world-changing kind of experience for you?
Yeah. I mean, I think I would have to go back to my first real global health emergency medicine experience. So as a second year resident, I took a 2-week vacation. It was my 2-week vacation, and I had found a program in Haiti that took medical volunteers. So I went as a group for a week with a bunch of nurses, doctors, RTs, medics, people from all sorts of different medical backgrounds to a hospital in Port-au-Prince in Haiti. And we just worked there with the local doctors, the local nurses. And I just remember, experiencing how to treat these patients without having the resources that I was used to having patients come in and, not readily having a CAT scan, not readily having a ventilator, or not, and making those sometimes really difficult choices. But I just remember being thrilled by it, just because you feel like you're making a difference, because these are people who really don't have any other options, or many other options at all. And, it's very common in these settings, in these very low resource settings, that people aren't seeking out medical care unless it's extremely necessary. And so to be involved with those patients, it's very fulfilling. And it kind of just really really sparked my passion for global health. And, after that week, I knew this is what I wanted to do. I knew was the environment and the people that I wanted to work with. So it really stuck with me.
That's great. That's great. If we had more time, I'd let you talk about how wonderful your experience was working with me in the emergency department and in research. But
that too.
We only, the time is, we're really short on time, and I know that would probably take another 45 minutes. Well, Aimee, it was so great to have you on today. You've got such wonderful experience. Your views are, I think real good take-home messages for our listeners who are interested in working in kind of low income, low resource settings, or who want to bring, educational programs to these areas. Do you have any social media that you are on? Are you on Twitter, MySpace? Yeah, I think MySpace maybe not the best way to
get my MySpace account. And
right, yeah. But you are on Twitter. Do you?
I'm on Twitter. Okay. Aimee T Tang, AIMEETTANG.
Great, and we can follow you there.
You can follow me.
Well, thank you so much. What's that?
It's like follow me, reach out, say hi.
Absolutely. Thank you so much. It's been a pleasure to talk to you again. It's been a few years since we've chatted. It was great to catch up. Great to hear what you've been doing in the last couple of years, and hopefully we'll get to chat again. So thanks again, everybody, and make sure to visit the World Extreme Medicine website for this and other podcasts, and also our live programming, as well as the World Extreme Medicine Fellowship. Thanks to all of our listeners, and we'll see you next time.